What is the most appropriate action when air is visualized in the venous drainage line? A. Increase the pump speed to push it through. B. Stop the pump immediately and clamp the lines. C. Increase the sweep gas flow. D. Lower the height of the ECMO console. Answer: B. Stop the pump immediately and clamp the lines. Explanation: air in the circuit is a catastrophic emergency. The pump must be stopped and the lines clamped to prevent an air embolism from reaching the patient. The source, usually a loose connection or a suck-down event, must be identified before restarting. Which of the following is the primary indicator of adequate perfusion during VA ECMO? A. Mean arterial pressure, MAP, greater than 65 mm of mercury. B. Mixed venous oxygen saturation, SVO2, greater than 70%. C. Serum lactate levels decreasing/stable. D. All of the above. Answer: D. All of the above. Explanation: unlike VV ECMO, respiratory, VA ECMO is for circulatory failure. Success is measured by global markers of perfusion, maintaining a target MAP, ensuring high venous oxygen return, SVO2, and observing the clearance of metabolic acidosis, lactate. In VV ECMO, if the recirculation fraction is high, what is the best anatomical intervention? A. Move the return and drainage cannulae further apart. B. Push the return and drainage cannulae closer together. C. Switch to VA ECMO. D. Decrease the pump flow. Answer: A. Move the return and drainage cannulae further apart. Explanation: recirculation occurs when oxygenated blood is pulled back into the drainage cannula. Increasing the physical distance between the tips of the two cannulae, e.g., one in the femoral vein and one in the internal jugular, minimizes this effect. A patient on VA ECMO develops a sudden increase in pulmonary capillary wedge pressure, PCWP, and frothy pink sputum. This indicates A. Successful lung recovery. B. Left ventricular, LV, distension and pulmonary edema. C. Oxygenator failure. D. Systemic inflammatory response syndrome, SIRS. Answer: B. Left ventricular, LV, distension and pulmonary edema. Explanation: retrograde flow from the VA cannula increases after load. If the LV cannot pump against this pressure, blood backs up into the lungs, causing acute pulmonary edema. This often requires LV venting. Which phenomenon explains why a patient's POW2 on VV ECMO rarely exceeds 100 mm of mercury even with 100% circuit FiO2? A. The oxygenator is inefficient. B. Mixing of oxygenated ECMO blood with deoxygenated native venous blood. C. Pulmonary shunting. D. Both B and C. Answer: D. Both B and C. Explanation: in VV ECMO, the return blood mixes with the patient's own venous return in the right atrium. Furthermore, any blood passing through the native non-functional lungs, shunt, remains deoxygenated. What is the bubble point in an ECMO oxygenator? A. The pressure at which air is forced through the membrane into the blood. B. The amount of CO2 bubbles in the sweep gas. C. The point where the pump head cavitates. D. The temperature at which blood boils. Answer: A. The pressure at which air is forced through the membrane into the blood. Explanation: the bubble point is a safety threshold. If the gas side pressure significantly exceeds the blood side pressure, or if the membrane is damaged, gas can be pushed into the blood, causing an air embolism. When managing an Avalon, dual-lumen, cannula, why is echocardiography essential for placement? A. To ensure the drainage ports are in the superior and inferior vena cava. B. To ensure the return port is aimed directly at the tricuspid valve. C. To check for a patent foramen ovale, PFO. D. Both A and B. Answer: D. Both A and B. Explanation: dual-lumen cannulae are position sensitive. If the return jet is not aimed at the tricuspid valve, recirculation increases dramatically and oxygenation fails. Which of the following triggers the low flow alarm on an ECMO pump? A. High systemic blood pressure. B. Kinked arterial, return, line. C. Hypovolemia. D. All of the above. Answer, D. All of the above. Explanation, any factor that increases resistance, kinks, hypertension, or decreases supply, hypovolemia, cannula suction, will cause the centrifugal pump's flow rate, L/min, to drop, triggering the alarm. What is the physiological effect of increasing the FiO2 on the ventilator while a patient is on stable VV-ECMO? A. Significant increase in systemic PaO2. B. Decrease in ECMO pump flow. C. Minimal effect if the native lung shunt is high. D. Increased CO2 clearance. Answer, C. Minimal effect if the native lung shunt is high. Explanation, in severe ARDS, the native lungs have a massive shunt. Increasing ventilator FiO2 does little because the air cannot reach the blood through the diseased alveoli. The ECMO circuit does the heavy lifting. During VA-ECMO weaning, what is the significance of the VTI, velocity time integral, on echo? A. It measures the thickness of the oxygenator membrane. B. It is a surrogate for stroke volume and cardiac recovery. C. It measures the speed of the sweep gas. D. It indicates the level of hemolysis. Answer, B. It is a surrogate for stroke volume and cardiac recovery. Explanation. As VA-ECMO flow is turned down during a weaning trial, clinicians look at the LVOT VTI, left ventricular outflow tract velocity time integral, to see if the heart can maintain adequate stroke volume on its own.